HR चिटमे। कृपया मंच पे आए। प्रोग्राम डायरेक्टर डॉक्टर प्रमोद कुमार सिंह थे, उनके यहाँ आज इंस्पेक्शन है इसलिए वो आ नहीं पाए। डॉक्टर अंजू यादव चेयरपर्सन है हमारी, कृपया मंच पे आए। और आमंत्रित करूंगा प्रोफेसर PN सक्सेना जी को, कृपया मंच पे आए। RK दीक्षित जी को कृपया आए और इस सेशन को शेयर करें। करना चाहूंगा अपने स्पीकर प्रोफेसर चिटमे का, डॉक्टर अजय गुप्ता है, अनुरोध है कि पुष्प द्वारा उनका स्वागत करें। मेरा अनुरोध डॉक्टर गुप्ता से कि हमारे चेयरपर्सन प्रोफेसर सक्सेना का स्वागत एक पुष्प द्वारा करें। का भी स्वागत। डॉक्टर अंजू यादव, डॉक्टर सक्सेना से अनुरोध है कि कृपया आएं और हमारे स्पीकर को इंट्रोड्यूस कराएं।
Good afternoon, everybody. We have Dr. Havagiri R. Chitme, the speaker of the session, and Professor Chitme is a professor of pharmacology at Oman Medical College campus and academic partner of the West Virginia University, USA. Dr. Chitme has received many awards and is one of the top scientists of his country, Oman. He has been nominated for MOH Standing Committee for Patient Safety Curriculum Teaching and Health Academic Institutions in Oman. He is a life member of Academia. He's designed and developed curriculum for BSc Nursing program of King's University, Accra, Ghana. He designed and developed curriculum for B Pharma, regular and B Pharma evening and MSc Clinical Pharmacy courses at Oman Medical College, Oman. He received his doctorate in 2004 and master's in 1998. He has a vast experience of 18 years, Kuala Lumpur, Oman, Singapore, and many other countries of the world. He chaired and co-chaired many sessions and the seminars and conferences abroad as well as in his own journals. And he has to his credit 2 books and 2 training manuals. So I now request him to deliver his lecture.
I express my gratitude to the organizing committee and each and every member of the members who have worked with the organizing committee, because I have seen many of the people roaming around and running to help the guests, the speakers, and they are serving like the children, like we don't expect even from our children. So they are going around us and they are helping and taking care of us like our children. And this is an honor for me to be here in the Kanpur. I thank the organizing committee, especially Dr. Ajay Kumar MP Gupta and Dr. Praveen Katia sir for their gracious invitation to deliver this talk on today. And it's an honor again. So what I am going to talk, so as you can see from the title of my talk, this is the specific strategies in preventing the gastric cancer. So our professor earlier talked, the speaker, Dr. Shraddha Singh, so she covered almost 90% of the things. So she finished all the main course and only left with me is the dessert, the jamun. So she made my job easier. So I hope almost most of you who are sitting in the front and the back and the middle, so they will enjoy my talk today. Okay, so what I am going to focus is, I hope it is most important for many of you, not all of you, because there are some exceptional also. So I hope most of you are interested in the topic. So here is the thing which I am going to talk. Let me take you through the country from where I come. So this is an Oman, the country from where I come. It is just across the Arabian Ocean. So if you just jump from the Mumbai, you land in the Muscat. That is an Oman, which is just across the Arabian Ocean. And this country is, so I brought the warmest greetings and as well as the best wishes to the organizing committee, to the speakers, to the chair, and to the delegates, so everyone. So now here, if you look into some of the aspects of the Oman and the India, so let me take you through some relationships which we enjoy. So India and Oman has a special place with respect to the Guru-Shishya relationship. So you must have seen the Dr. Shankar Dayal Sharma. So Dr. Shankar Dayal Sharma is happened to be the teacher of our king, His Majesty Sultan Qaboos. So we enjoy the Guru-Shishya relationship. So still this relationship is being extended by the new generation, some of you might have seen the Asma Balushi, who was the participant in the Saregama TV reality show. Then recently the Haitham Al-Balushi, he won the Dila Hindustani contest also. So he was one of the participants in that one. So we enjoy the relationship from the old generation to the new generation. Now here is this is my second visit to the Kanpur, and the first visit was very personal, private and very special. You can see Dr. Ajay Kumar MP Gupta Sahab and with the family. So I celebrated my birthday at his home. So I came specially to celebrate the birthday on special invitation from Dr. Ajay. Okay, I will take you through some pictures of the Oman. So this is a beautiful Cornish. So we have the beautiful beaches and the beautiful palaces. We have beautiful bare mountains, even some bare mountains and the green mountains. And we can also enjoy this bouquet of Oman Medical College. So you can see all the nationalities who are there. It's the Oman Medical College bouquet. You can see, you can pick the flower whatever you like. Okay, we have the two campuses. One is in the Muscat, another one is in the Sohar. Sohar, this is the capital of refinery. So we have the two campuses, and both the campuses, we have the mutual understanding. So the faculty goes and comes back, and we have the interdisciplinary teaching, by which the students they start understanding each other and they work together as a team. So here is the outline of my presentation. What I am going to talk. So I will be giving a brief the trends on incidence of the gastric cancer and as well as the rate of mortality. Then I will be taking you through the risk factors and the causes. Then the challenges which are involved in the management of the gastric cancer. This is very important for the challenges what we are facing and the path ahead. Then we have there are some take-home messages. I made the 8 points. I think that maybe you can reduce some to 6 or you can increase by 10. Okay, here is the first slide. This is nothing but the gastric cancer. So the gastric cancer is the cancer which occurs in the lesser curvature of the stomach. And here most of the patients, they are diagnosed in the later stage of the gastric cancer, not in the early stage of gastric cancer. So Dr. Singh, so she already covered the pathophysiology, how the mutation occurs and how the genes have their own role in suppressing the genes or improving or causing the cancer, that is oncogenesis. Let me take you in the simple steps, which we call as chorea cascade multi-step gastric carcinogenesis. This is the example of chorea cascade multi-step chorea cascade multi-step gastric carcinogenesis. So here you can see, so there is a chronic gastritis. It is a non-atrophic. So once it turns into the atrophy, then the atrophy is followed by the damages to the chief cells and as well as to the parietal cells. once the damages happens in the parietal cells or in the chief cells, then these cells will start destruction. So this will cause a decrease in the acid secretion, which we call as an hypochlorhydria, or it may cause an achlorhydria. So this hypochlorhydria and the achlorhydria, this becomes a host for the H. pylori infection. So here, if a person is having the gastritis, he has a risk of developing the gastric cancer. So here, if we see, this will cause an metaplasia, then dysplasia, then it follows the neoplasia. So if you look into the cancer incidence in India, because some of the media persons, they asked, so how do you correlate the incidence of the stomach cancer with the stomach cancer in the India? So this is the figure which shows that in the 2015, the figure which shows the gastric cancer, all type of the gastric cancers are in the rise. So they are on the rise. So the others are declining because we have the better management strategy. But the gastric cancer strategy is weak in the management. So that's why the gastric cancer trend is increasing. So rest of them, because as Dr. Singh said, you stop the tobacco, chewing, smoking and all those things. So now because of the more awareness, so the other cancers are declining, but the gastric cancer is increasing. This is again, so if you look into the globally and as well as India, so there is the third top level. So here is you can see the stomach cancer is the third topmost cancer, and in both men and as well as in the women. So it's globally also it's the third topmost cancer, and most commonly it occurs in the Japan, then into the European countries, in the middle of the America, then again in the European countries. So now here what is estimated is that the WHO it has estimated that the cancer incidence will increase by 40%, and the death rate due to the gastric cancer is going to increase it by 32%. This is a concern which we must be very careful about the stomach cancer. And there are many risk factors, as in the morning, so everyone has spoke. There are even His Excellency, he spoke about the causes. So we don't know the cause behind the gastric cancer as with the other cancers, but we know the risk factors. So we say this gastric cancer is the cancer or the disease having multiple diseases. So if you take all the diseases together, it will become a gastric cancer. So exact cause behind the gastric cancer is not known, but we know the risk factors. There are multiple risk factors. The environmental factors, infectious agent, dietary factors, genetic factors. So there are multiple factors which are there for the incidence of the gastric cancer. Even the poor sanitation. If you take any governments who are in the power, they always insisted on the hygienicity and the proper sanitation. It is because it may also have the risk of developing the cancer. So we must be very careful about the hygienicity and as well as the sanitation. Now here is a cancer case. If you go back, so which type of the infectious agent is causing the most cancers? Infectious agent. The H. pylori comes 36%. H. pylori is the most common infectious agent which will cause the cancer, and they followed by you have the HPV and others. So now the H. pylori again, all the H. pyloris are not the risk or the causes for the stomach cancer or the gastric cancer. So there is one special strain which is called CAG, cytotoxin associated gene A. So this cytotoxin associated gene A is having the higher risk than compared to the other type of the H. pylori infection. So there are other mechanisms by which the H. pylori causes, but what we know is H. pylori causes the two type of the gastritis. One is an acute, another one is the chronic. But the chronic may lead to the development of the gastric cancer due to the metaplasia and the reactions. Okay, here is some of the things which we must remember. So the meat, especially the red meat and the processed meat, so they are as risky as that of the smoking. So in the stomach cancer, this is the very important one. So we must remember the processed meat, cheese, and as well as the red meat, they have the higher risk equal to the risk of the smoking. So let me show you the video of barbecuing. So look at the process by which they barbecue, but the barbecuing is good. But what is happening, you can see, and as well as some improper method of barbecuing. Look at the meat, how it is barbecued. It is totally turned into the black. So as we know, so if the meat or the red meat or the processed meat, if it is heated at a higher temperature, then it will lead to the release of the nitrous compounds, the HAC, the heterocyclic amino carbohydrates. So here the pH and as well as the H. So here this is which you can see is the barbecuing. So the process of barbecuing is also very important. So whatever the barbecuing they do, so it should not be heated at a higher temperature because it leads to the generation of the nitrous compound. So similarly here, these nitrous compounds, once they are generated, these nitrous compounds damage the DNA and causing the mutation. So if you look at which part of the stomach is most commonly affected, it is the proximal and it is the lesser curvature of the stomach. So proximal and the lesser curvature of the stomach is most commonly affected. But those which are rarely occurring, they are having the poor prognosis. This we must remember. The other cancers which are occurring in a less numbers, but they have the poor prognosis than compared to the lesser curvature cancer and the proximal cancer. Now, there are some problems in the management of the gastric cancer because in the early stage the cancer remains asymptomatic, but as it progresses it starts leading to the symptoms. But most of the symptoms, if you look into the symptoms, most of the symptoms are the common symptoms. Nobody will take it seriously. Everyone starts ignoring it. So because the symptoms are like gas, the pain, abdominal pain, and the dysphagia, dyspepsia, so heartburn. So these are the common symptoms. Everyone starts ignoring these symptoms and they think, okay, there's no problem, so we take the antacids or we take the food. But when they take the food, this is very important for all of us, those who are studying and as well as who are practicing. So if any person did not recover by taking the antacids or by eating by taking the food and his pain is not reduced for 4 weeks, then you must advise the patients to go for the higher investigation because the pain must be reduced within the 4 weeks if it is an ulcer. If it is not reduced, it means there is a risk of developing the gastric cancer. Now here if you look into the survival rate is just 30% in a 5-year survival rate. Even after this, but the survival rate again it varies with respect to the stage of the gastric cancer. If you look into this, so here is a localized, only the 27% of the patients are diagnosed in the localized gastric cancer and 28% are regional and 35% are distant. Means very few, 27% of the patients are being diagnosed in the stage 1, then later on it goes into the higher numbers. As it goes higher, then accordingly the rate of mortality is also more. So if you look into this is a 67%. If they are diagnosed in the early stage gastric cancer, then the survival possibility is 67%. But in the stage 2 it goes to 30%, stage 3 it goes to just 5%. And even the 5%, the survival rate is just within 8. Now if you look into the management, what is the problem in the management of the stomach cancer? The major, the solution for the gastric cancer is the surgery. It's the surgery. But if the diagnosed in the early stage, if it is diagnosed in the late stage, then the surgery is not possible. So here we have the neoadjuvant therapy, we have the surgical therapy, which is a total gastrectomy. If it is a proximal one, you can go for the total gastrectomy. If it is a distal one, you can go for the subtotal gastrectomy. But again, there is a risk of recurrence, and the risk of recurrence is 40 to 80%. Risk of recurrence is again high. So now you have the surgery, then you have the chemotherapy, but we must remember the chemotherapy is not effective. The chemotherapy is just increasing the survival duration by 9 months. 27 months is increased to 36 months. Again, the single chemotherapy regimen is not effective. Again, you should go for the Macedoine regimen. Again, the 3-drug chemotherapeutic one. And here the biological therapy, so people are trying to use the Herceptin to cure again it is not also effective, only it is effective in 10-20% of the patients who are expressed with the hormones. If there is no hormone, the Herceptin is again not effective. Now the palliative therapy, where you can use the radiation therapy as a palliative therapy also, but radiation therapy alone is not effective. Now what is the challenges in the management? If you see, so there are many challenges. Challenges because the patient is not coming to for the diagnosis in the early, as the patient is remaining asymptomatic. And the patient, maybe it is the misdiagnosis because we most preferably we go for the 3 biopsies. So single biopsy gives the diagnosis of 70%. The 3 biopsies gives the diagnosis of 80 to 85%. So there is no 100% diagnosis. But if you want to diagnose 98%, then you need to take 7 biopsies. So again, it becomes complicated. So sometimes they are overdiagnosed, that is 20% of the patients are overdiagnosed, 10% of the patients are underdiagnosed. This is also the problem with the diagnosis of stomach cancer. And it's a late detection because the patient comes with the symptoms, so they will be late in treating and incorrect in staging, because most often they use the endoscopy for the diagnosis. When you use the endoscopy, the staging again, it's a submucosa to the mucosa. If it is restricted, then we say it's an early gastric cancer. But if it crosses, then only we say. But some of the people, they see the tumor in the lymphatic nodes and they categorize them as a stage 2. So there is the staging is also, there is some problem. Now, the failure of the chemotherapy, as I said, it will improve the sign and the symptoms, but it will not improve the survivability of the patient. So there is a high risk of metastasis, which we can see. Now here we are trying to pull the stomach, pull back the cancer, but it is not in our control. It is going beyond our control. So now what is the path forward? What is the way forward? The way forward is only the prevention. Only the prevention. Now I am going to talk about the research which I have done in the Oman for 2 years of period. It is the cross-sectional, it is a case control retrospective study. I used 153 patients who suffered with the stomach cancer and compared with the 153 age and gender matching patients. And I think this study is more relevant to you because it has all the ingredients, whatever you are expecting in your conference. This study I presented in the Kuala Lumpur as in the Asian Oncological Society conference, and it is abstracted in the European Journal of Cancer. Now here is this study was carried out not as extensive as the professor saying. So I carried out only in collaboration with the Dr. Mansoor Mandari, who is an oncologist in the SQU. So because we say working together brings the success. So we all have to work together to fight against the cancer. So always we should keep our mind open to come together and fight. So here is the study instrument which I have done it in the tertiary care hospital called the Sultan Qaboos University Hospital, and it was an 153 plus 153 case control study and retrospective analysis. Now this is a trend of incidence of this gastric cancer in the Oman. So it is now it is 86 is going down to the 72 because the ministry has taken a lot of steps. They are considering each and every publication and the presentation, and they are publishing the brochures and spreading the reason wherever there is a higher risk. So this study I did it in 2014-15, and now it is now the stomach cancer is the 5th commonmost cancer in the Oman, and here is the frequency of occurrence with respect to the age. If you see, the frequency of occurrence is more in the 46 to 50 years, but the relative risk is very high. It's 2.2 times in 20 to 25 years of the age. And the literature also says if there is the H. pylori infection in the early age, the risk of stomach cancer also increases. It's 2 times, and 31 to 35 years have the 1.5 times of the control group. Now the gender distribution, male is having the 1.29 times then compared to the females. And here is the risk of with respect to the type of family and the incidence. Nowadays everyone is working, everyone wants the freedom, and if the wife and husband, both of them are working, so they start having the habit of the fast foods, and this is an increase in the risk has been we observed. The unity families have then 2.6 times of developing the gastric cancer than compared to the other group of families. Now here the widows, so 1.3 times than compared to the normal. And here is the occupation and incidence. We did not find any risk with the occupation and the incidence. And if you look at the level of education, uneducated and primarily educated the women, so they have the higher risk. So here is let me stop here. Let me pause here for some time because what we found is being taken care by the Ministry of Health seriously. And we found that there is an increase in the risk by 3 times in the Dofa region. The Dofa region is the region which comes just bordering to the Oman and as well as to the Saudi Arabia. And their style of eating, their nutrition habit is different, and their lifestyle is also different. They recognize themselves different from the other parts of the Oman. So we found there is a 3 times increase in the risk in the Dofa region, and Al-Badna region is 2.2. This Al-Badna region is the region, it's just coastal to the sea. So they eat more fish. So let me take you through the some specific method of cooking, how they cook so that you can understand the way of cooking. So this is like in tandoor they make, especially during the Eid celebration or the get together, and they keep this camel. So either the meat of the camel or the whole camel they insert into the tandoor and they cover it for 2 days. They cover it for 2 days. After 2 days they take out and make the pieces and they eat. So this is a traditional method of cooking and everyone likes. So if you go to that region, so everyone starts liking this kind of the meat because it is more tasty. So this is a method of cooking, so this they follow. And then, so here is another video, let me show you the salting of the fish. So this is in the coastal area, so they don't use the refrigerator to store the fish. They use the traditional method of salting. So you can see the salt is inserted. This is a salinization of the fish to preserve the fish and to remove the water so that the Clostridium spores will not develop. So they follow some traditional method of salting the fish and as well as cooking the camel meat. So then when we presented this to the Ministry of Health, then they have taken it seriously and then they published some brochures in the region and they advised the people to go for preserving the fish in the refrigerator rather than salting it. But you know, whenever you add the salt, it will be more tasty. So people are still hesitating to eat the fish which is refrigerated and they go for more traditional one. This is the salinization. Okay, here is an hereditary factor which we focus. So there is an sisters and the mothers, they have the higher risk, 1.5 times if the sister has the gastric cancer, and the mother is having the risk of 1.25 times than compared to the other groups. So here is the family history of the other cancers. There are literatures which says that there is a relation between this gastric cancer, colonic cancer, and the breast cancer, because BRCA1 and BRCA2 is also associated with the gastric cancer. And even the colonic cancer also, as you see, the BRCA1 and BRCA2, then again this linked with the colonic cancer, but we did not find any relation with the other cancers. So here is the influence of the RS factor for our surprise. Most of these studies, they shows that RS positive has a risk, but RS negative has no risk. But in our study, it could be because the sample size was less. So we found that there is a 2.3 times risk is with the RS negative, because RS negative people population is less. Now here is the blood group. Blood group A has a higher risk of 1.3 times, and the group B has a lower risk. Again, lower risk. Again, it is higher than the normal 1.11 times. So the exact reason we don't know. So there are the risk of the blood group A also. Now this is a very important one. What we should all must remember as a healthcare professionals. So there is an use of the S2 blockers, PPIs, antacids. This we found. So the use of S2 blockers, S2RAs, then PPIs and the antacids, they also increase the risk of the gastric cancer. So as a healthcare professional, we must use them with the care, because they must be using for treating their ulcer. But if they have been used for the longer time, that is increase the risk of gastric cancer, because they will also cause them hypochlorhydria and achlorhydria, which becomes the good host for the H. cholera infection. Okay, here is the others, the antacids. So also increase the risk, but here is the influence of the endoscopy. So if you make more damages to the gastric, so there is a damage to the parietal cells, which will also decrease the acid secretion, which will again increase the risk of gastric cancer by 2 times. Now here is a peptic ulcer disease, also increased because the peptic ulcer disease, again 2.83 times. Now here are the many factors, as Professor Singh already mentioned, the alcohol, smoking, so they increase the risk by 4.5 times, 4 times and 3 times also. Now here is some other factors which will increase. The maida they eat more, and if you look into the cheese also they eat more, so again they have the higher risk of developing the gastric cancer. Now here is some traditional food, what you find it in, especially in the Omani people, so they eat this one. But don't get confused with the halwa. The halwa what they eat is different from the halwa what we have. We have gajar ka halwa, we have bodyguard halwa, we have many halwas. But their halwas are made up of the cornstarch or with the maida. Either they use the cornstarch or they use the maida. So again, they drink the kahwa, what we say is a coffee. But that coffee, they don't add the sugar. So they eat halwa and they drink the coffee. So if you eat halwa and drink the coffee, then the coffee also have the higher risk along with the halwa. So the halwa is more they eat. So the others are the other traditional factors. But let me take you, so these are very important ones. So I think the chair is very kind to give me some more time. Okay, now okay, sir. Okay, now let me take you to some of the risk factors which can reduce the factors which can reduce the risk. This is a very important point for all of us to learn. So if you take the tea, so we asked about the tea, so how frequently they drink the tea. So if you look at this, 1 cup per day, 2 cups per day, 3 cups per day. So it is continuously, consistently it is reducing the risk. So 1.52 times was the 1 cup per day, then again 1.12 times it is in the 2 cups per day, and 3 cups per day it has reduced the risk by almost half. So it's a 0.5 times. The person will have the better health with the 3 cups of the tea. So I advise you to drink more tea. 3, but not more than 3, again 3 to 4. You can have it, but don't have more tea. So again, it may have some other actions because we have not studied anything about that. Now here is an yogurt. Yogurt is the little different from the what we have. It's like the curd. So it is the thickness, the consistency is more thicker. So here's having the curd, which will also give you the lactic acid. The acidity in the stomach will increase, and the risk of having the H. pylori infection will be reduced. So the lactic acid. So because of this, you can also see having the yogurt has reduced the risk from 1.43 times to 1.12, then 0.46. Again, half of the risk is reduced by having the curd. Now here are some of the most significant factors which reduce the risk of gastric cancer or the sugar-based sweet desserts. So after the meals, if you take some sweets, so this is protecting the mucosa, and thereby it may be reducing the risk of the gastric cancer. Vegetable salads, so they can also reduce the risk of the gastric cancer. Look into the consistency. So if the consistency is 1.39 times, then again the 0.26 times, 0.1 times. So it means almost 90% of the risk of developing the gastric cancer can be reduced by consuming more and more vegetables. But as a word of caution, we must remember, so whenever we eat the vegetables, it's always better to eat the raw vegetable. But the problem is, so there is a lot of contamination. So I advise you to steam the vegetables before you eat. So steam the vegetables before you eat to avoid the contamination and as well as having the risk of the infection. So here is the risk is reduced significantly. Now we have some other risk factors which are reducing: the fruits, regular use of the fruits and the fruit juices. Again you can see, so it is 0.14 times. Fruit juice, the fresh juice, then you can also take the veggies. So the cooked vegetables 1 to 3 times. So again it has reduced the risk by almost the 84% of the risk is reduced. And the milk and the ice cream also can reduce the risk. So milk has reduced, but again there is no significant effect with the ice cream. So please make a note. So ice cream has no effect, but it is 4 times, then 2 times, then 1 time. So it is almost the normal. But don't go for the ice cream, go for the milk. Milk is good for all of us. Okay, let me give you this word. This is you don't have to see the whole staircase to take the first step. So the first step has to be taken to prevent. So either you should go for the primary prevention or you should go for the secondary prevention. So don't look at the whole step. So this is the stage 1, stage 2. I have the chemotherapy, I have the hormone therapy, I have the biological therapy. So nothing will work. So what works here is the prevention. So either you go for the primary prevention or for the secondary prevention. So if you take care of yourself, because you are taking care of for your health, you are not taking care for the others. So you take care of yourself. So here are the 8 steps. They are the take-home messages. The first one is mask wearing is not advisable because it is an expensive one, and all the people are not at the risk of developing the gastric cancer. So mask wearing is advisable only in Japan, and Japan has made it compulsory to reduce the risk, and they reduce the risk from the 50% to the 20%. The cancer incidences are reduced from 50% to the 20% now. So because they involve the esophageal ultrasonography, which is a must for the diagnosis. The others also several the antibodies for the H. pylori screening also they are following, but this is not recommended in other countries, only in the Japan. Now here some primary, specific primary and secondary preventive measures are very important in consideration of the individual risk factor. As our His Excellency Governor Sahib, he advised us to talk to the patient. This is very, very important. Talk to the patient to know what kind of the lifestyle they have. So if their lifestyle, like if they don't eat the meat, and you say, okay, don't eat the meat, so he's vegetarian, so it is not applicable. Then they will think, okay, this guy keeps talking like this, so don't listen to him, he's crazy. So, but we must listen to the patient, ask the patient to find out what risk factors are associated. So accordingly, you need to advise the patient, okay, you stop or you reduce this risk and all those things. Now the next one is the early gastric cancer diagnosis is very important, but unfortunately only 20% of the patients are diagnosed in cancer. The 80% of them, they come in the advanced gastric cancer stage. Early gastric cancer only 20%. Rest of them are in the others. So we must think of reducing the diagnosing in the early stage. Avoid unnecessary and excessive use of the STRAs, PPIs, and the antacids. Now here, if a patient is found to have the H. pylori infection, we must go for the H. pylori eradication regimen. So either the 3-drug regimen or the 4-drug regimen. Remove the H. pylori. This is very important. Remove the H. pylori, so the risk of developing the gastric cancer also will get reduced. Now here, I do not recommend the antioxidant. This is very important again for all of us. We must follow our ethics in the profession. So don't recommend anyone to go and take the antioxidants, because the vegetables have the antioxidant, fruits have the antioxidants, tea has the antioxidants. Then you also take the antioxidant, it will prevent. It's not correct. It's not true. So the taking the antioxidants have no protective effect on the gastric cancer. So because the antioxidants are free from the fibers. We need fibers as well as we need the antioxidants. So if you take the fruits and the vegetables, they provide both, and both of them are required to prevent the gastric cancer. So don't advise the antioxidant tablets like vitamin C, vitamin E, selenium. Okay, here is an cancer which will the check risk before you give the PPIs or the STRAs or the antacids. Check the risk of the gastric cancer. If the family has the gastric cancer, or if there is a mutation of the cat, then you should not go for the STRAs or the PPIs. Now here, educate the patient on the family dietary habits, the childhood habits, the way of preparation, which I have shown the videos. So the way of preparation is very important to avoid the release of HCS and also the PAs. So to avoid the formation of nitrous compound and eating them to cause the DNA toxicity. So educate the patient, this is very important, and we must remember that one size does not fit all. So you take the risk factors into the consideration, so before you advise, because everyone's food is different, everyone's food size is different. So if you don't make it as a generic advice. So go specifically to the patient so that the patient will be happy and they will feel better. Okay, this is an acknowledgement. So before I stop, this is my duty to acknowledge the help of Dr. Mansoor Al-Mandari, who is an oncologist, and the facility which is provided by the Sultan Qaboos University Hospital to get 153 patients, stomach cancer patient, and the 153 patient who has undergone the surgery was the difficult task, but he convinced the administration to give the permission to carry on the study. And the Nazal Salmi, who helped me in collecting the data, because I cannot talk in Arabic because I don't know the Arabic. So I took the help of my student, so she was with me and in collecting the data. And thank you very much, sir. Thank you. I hope I have not taken more time.
It was a lucid talk and covering all the aspects of the gastric cancer. And I thank Professor Chitme for giving such a wonderful talk and information which is relevant to our country also. Only the query is that most of the times we go for the eradication of the H. pylori, but there is a chance of reinfection. So once you eradicate by the eradication therapy of H. pylori, for how long it remains eradicated? Because suppose it comes again, so there is no use. So for how long it remains to be, and for how many times it should be eradicated?
So I am not aware of this research which is happening in the H. pylori eradication, but I believe that the H. pylori eradication will be effective, and if the patient is following the proper hygienic and the sanitation, and it is a recurrence rate is again higher because there is a toxin which is released by the H. pylori goes deeper into the mucosa. Because of that, there is a higher risk of the recurrence. So because when you go for the antibiotic regimens, so these eradication regimens, they eradicate whatever the maximum, but those who penetrated deeper into the mucosa and the submucosa, so this eradication is difficult. So I think the practitioners can answer it better than me.
Research topic. So that once you eradicate the H. pylori, for how long it remains eradicated? Because in our country, where the hygienic conditions are very poor, the recurrence is very high, very high. So and the H. pylori eradication itself, they have their limitations. So, and the second is query regarding the hyperacidity versus achlorhydria. The achlorhydria is the known factor for the gastric cancer. On the other hand, hyperacidity also. So what is this controversy? Can you give some input?
One of the slide. So the patient who has a history of the peptic ulcer disease, they have also the higher risk of 2 times than compared to the normal. So because the acidity it will cause then again damage to the mucosa. Again mucosa will get damaged, and which may be associated with the parietal cells also. So this may cause the degeneration of the cells and leading to the dysbiosis.
Thank you, sir.
Thank you very much.
बारी है फेलिसिट हाँ सर
Chitme for a very elaborative talk on the gastric cancer, which is a very important part of the whole GIT system, and where you highlighted 2 important things. One is that the female sex is more prone and or the male. So that means there is some interplay of the Y chromosomes. You suspect, because if it is going from father to son or to daughters, it is the Y chromosome which is responsible. So what is your view in this regard?
I think so this is a matter of discussion, because if you look into the risk with the male, it is 1.29 times than compared to the control in the male, not in the female. But if you look into the other options, the risk, those with the family history, the sister and the mother have the higher risk. If there is a higher risk with the sister and the mother, if they have the previous history, sister or the mother suffering with the gastric cancer, then the offsprings have the higher risk of developing the gastric cancer. So I don't know whether it is linked with Y chromosomes or not, because it's a matter of discussion and the debate also. Because if you look into the risk is more in the male, but from where we are borrowing, so we are borrowing from our sisters and the mothers. So,
then the good thing is that you also cited that the people who use the red meat,
yes,
they are the victims of gastric cancer.
yes, sir.
So it means most of the people in USA, Japan and the Arabian countries, they are the red meat eaters. So the incidence of cancer is more in compared to the other part of the world.
Yes, sir, this is true that the stomach cancer is most common in the Japan, then in the Europe, and in the middle of the America. So not in the Northern America, Southern America, it's in the middle of the America, the risk is more. And the red meat, it's because it contains the nitrosomethyloglobin, what we study. So it is a nitrates which are present more, which will give the more color, because when you take when you make the meat red in color, so its taste is also different. I don't know, so because I'm a vegetarian, so the people they say the red meat is having the better taste and as well as the better appearance. So and this red meat is the color is given by infusing the nitrates. So when you infuse the nitrate, so this nitrate will react within the heme, and it becomes the nitrosomethyloglobin. So this nitrosomethyloglobin, when it is metabolized, then it releases the nitroso compounds, and these nitroso compounds will cause the DNA toxicity.
Last question is the blood group, A blood group. People,
I don't know the reasons of it.
because you cited in your lecture.
Yes, sir. Yes, sir.
So then I would say that DESSER is always remembered,
Yes.
because you started your lecture with this, and so it's very true to your lecture, because you narrated everything about the gastric cancer, different aspects, and the preventions, the preventive strategies also discussed. Thank you very much.
Thank you very much, sir. Thank you, sir.
The National Institute of Health, US, they have said that people who are using these plastic containers for eating their dietary items, they should avoid it as much as possible, because it contains those chemicals which are carcinogenic in nature, and their carcinogenic potential increases when they get some impetus in terms of the energy, and that is the microwave, because it is also having energy.
Yeah, just I would like to add one point, because one of my colleagues is working on this microwave effect on the embryos. So microwaves effect and the radio waves effect also, because he is keeping some mobile and checking the chicken embryos, how they are progressing. He is an anatomist. So he looked into, he dissect the embryos and he is observing. But what he found is like the microwaves are also quite harmful. And he found that there is an undergrowth of neurons. So this is what I would like to add, because I know one of my colleagues what he is working on. So even the radio waves also, especially the radio waves, like the tower which have the multiple radio frequency antennas, so they also have some harmful effect on the body. So especially we have observed it in the chicken embryos.
Your talk was quite elaborate but equally interesting, considering the relevance that this cancer is the third most common cause of death these days globally. But knowing that desserts are good is again a very nice thing. Thank you so much.
But ice cream is not good.
Yeah, got the point.
डॉक्टर के पांडे कृपया आएं और हमारे स्पीकर को फेलिसिटेट करें। मेरा अनुरोध है डॉक्टर महेंद्र सिंह से कृपया आएं और हमारे चेयरपर्सन प्रोफेसर PN सक्सेना जी को फेलिसिटेट करें। दूसरी चेयरपर्सन डॉक्टर अंजू यादव को फेलिसिटेट। नेक्स्ट टॉक है न्यूट्रिशन इन कैंसर। स्पीकर ऑन द वे है, 5 मिनट में आ जाएंगे। 5 बजे से इनका टॉक शेड्यूल था, अभी 5 बजने में 15 मिनट है। नहीं आ रहे, हाँ उससे पहले कुछ कहना शायद कह सकते हो। और इनके स्पीकर हैं अभी।